Thank you. All right, all right, thanks. Can we get a President of the Senate a round of applause? You know, he said he served in the Senate for a long time. He is the longest serving President of the Senate in the history of this country. Can we give him another round of applause? Well, we're very grateful, as I said yesterday, to have you here. First of all, let me just say to Judge Missouri, thank you so much for all the leadership that you have shown in Prince George's County, in the American Bar Association, and in Prince George's County to get people involved in the American Bar Association. I also want to recognize and thank Karen Polk-Onokwe for all the work that she's done and around it. Can we give her a round of applause? I do this because in no small measure, as you know, in the American Bar Association, getting people involved and staying them and keeping them active. Many of us, while we're in law school, we're eager, we're hungry, we join and then we drop out. So folks like these keep people actually involved in what's going on. Because this is an area where my expertise is little, we have folks who are here that are helping me out who actually deal with this crisis of opioid addiction day to day. One is our health officer, Pam Creekmer. You can stand up. And our Deputy Family Services Director and Head of Aging, Teresa Grant. Teresa actually served as acting director for almost the entire point of my administration. Yeah, no, it's almost, I told a story yesterday about, you know, Judge Missouri making a mistake when I came in. As the president said, when I came into office, there was a crisis here in Prince George's County. And so people would feel sorry for me and they'd go, man, I just really feel bad for what's going on. Is there any way I can help? And I said, well, thank you. And I make them volunteer. So Judge came on and helped us straighten out our county law office. And then Teresa said, hey, any way I can help, Mr. Baker? And I was like, great, here you go. And gave her a problem for a long time. As our historian and president of the Senate said, you know, Prince George's County is right next to the District of Columbia. And that's good and that's bad. The good part about it, as you see the economic growth around this county, you look at the District of Columbia, and if you've been away for a while, it looks totally different. There's growth everywhere. Well, that's the same way if you went to school at the University of Maryland, or you lived in Prince George's County, or you were stationed here in the military, it looks totally different. We now have gone from, you know, having economic development just here in this harbor area to the 500 square miles of our county, you see economic development all around it. Those are the good things that happen by being close to the nation's capital. But there are also the bad things that happen. That is, when there's a problem, whether it's addiction or other things, in the nation's capital, we get it right here because we're next to it. And in terms of opioid addiction and overdose, it's not just the District of Columbia. For us in Maryland, it is throughout. And so for those of us in Prince George's County, we happen to be right next to Anne Arundel County, and which is having this crisis as well. And for us, that means that some of those things that affect us are, you know, spill over. I gave this example when I was at the end of the session, in that the case that highlighted, especially around opioid, you know, addiction and deaths, was there was a case where that we had a gentleman, I believe it was a gentleman, maybe a lady too, in a hotel that overdosed. And we did an investigation and found out that they actually were from Anne Arundel County, which is right next to us. But they came over here because there was a cheap hotel. And it just brought home that this is an issue that's going on all around us. So for us, when it comes to the seniors, they gave me some facts here that to tell you about, you know, our population in Prince George's County. For us, a quarter of the county's population is age 55 and older. So that's nearly 220,000 residents are over 55, including myself. That gives you the general idea that of the landscape of our population. We're an older county. When it comes to opioid here, the general data for us may already be well aware to many of you. Nearly 9 million Medicaid Part D beneficiaries receive opioids for their pain that is associated with cancer treatment or hospice care. So there's plenty of opportunity for abuse. After hospitalization, 15% of seniors enrolled in Medicare were given new prescription opioids. So there's access to drug abuse. Seniors taking opioid medications are 4 to 5 times more likely to suffer a fall or a fracture than those taking non-opioid pain medication. So the factor of they can lead to abuse also. Here are some of the data about the impact of opioid use in the state. 86% of all intoxication deaths that occur in Maryland in 2015 were opioid related. Opioid related deaths include deaths from heroin, prescription opioids, and non-pharmaceutical fentanyl. The number of opioid-related deaths increased 23% between 2014 and 2015 and have more than doubled since 2010. The largest increase in the number of heroin and fentanyl-related deaths are largely responsible for overall rise in opioid-related deaths. The deaths from prescription opioids has been rising as well in recent years. Between 2014 and 2015, the number of prescription opioid-related deaths increased 6%, from 330 to 351. So now we frame the issue of opioid-related deaths in the county. But what I would like to talk about for the few minutes that I have here, and maybe have Pam and Teresa, add on, is the numbers are there. But for us at the county level, how does it become real? The President of the Senate talked about what was done this year in order to deal with the abuse around opioid-related deaths and prescription drugs at the state level. And he's right, we passed a bill this year to actually do a coordination, right, Pam? It's a coordination for the areas around how we deal with this issue. So at the end of the session, after this bill was passed, and there was some money put in it to actually coordinate the efforts throughout the state, because if you're in the western part of our state, if you're in Carroll County, Harford County, in those areas, this is an epidemic. If you're in the eastern shore, the same thing. And it's now starting to round itself to Prince George's County. So there is money for coordination. But what we find ourselves, and where I think we need your help, is the battle not just to coordinate how we all deal with. So the state, there are, 24 jurisdictions. There are 24 jurisdictions in the state, so coordinating our efforts is important. As I said, Anne Arundel County is right next to us, Charles County to the south of us, Harford County, Montgomery County. Coordination is great. Where we need help, though, is funding in the health-related area. What we don't have are beds to deal with addictions. We don't have the staffing that we can monitor for folks who are given prescription drugs and to make sure that they're not abusing those. If we arrest folks, and there is some, that you can send to drug courts, but most of the people who are going to be arrested are going to go to our jails. So the way it works in our state of Maryland, the jails are run by the counties. So right now, if you get arrested, no matter what your age is, and you come to Prince George's County jails, we don't have the capacity to deal with you in the health-related issues around drug addiction. If you go to Harford County, where the county executive there will tell you, he does not have the ability to handle this epidemic. So there is not enough around for us in terms of health-related issues, legal issues, and so that's really where the battle is right now in the state. The battle is about how do we deal with the epidemic, how do we make sure from both a public safety standpoint, and that is our legal system, but how do we also deal with it from a health standpoint? Because it's not just making sure there are beds available for treatment, but also that there are follow-ups for people who could become addicted by accident. And what do I mean by that? What I mean by that is a couple of months ago, I'll give you an example. Ms. Creekmer and I went to, with a group of other folks, we went to Cuba. And the idea at that time was really to look at, trying to get businesses to come here, but also looking at some things they were doing differently than we were in the States. One was education, but the other was healthcare. And while they're clearly way behind the United States on healthcare, there was an interesting thing that they did, and that was a comprehensive approach to keeping people out of hospitals. And I'll connect it in just a second. What it meant was, when you went home, they got you out of hospital, you went home, you had your own doctor in your building that can check on you. You had your own nurse that can make sure that you're following the prescriptions and taking the drugs you need, so that you wouldn't end up back in the hospital. That's something we need here in the States, but it becomes important in this respect because the accidental overdose, in many cases, especially as you get up in age, is because you don't follow the prescription the way it should be. You may take too much, too little, you may take it longer than you should be, because basically you're monitoring yourself. And so when you're looking at this issue from a standpoint of, from mine as county executive, and you're trying to figure out how to make the quality of life better, the real issue for us is how do we make sure that when someone who does not have a drug problem before they're given these drugs doesn't develop it. And the only way that happens is monitoring. Because once they get a drug addiction, then you get into the treatment phase and the bed space. But before that, how do we make sure that people are taking the drugs when they need it, they're not taking it over, and they're not leaving it so someone else could get a hold of it. And so for us, and I guess for you in this workshop, as you look at how we curb abuse, those are the areas that I think you should look at. One, how do we make sure there's beds available if there is abuse? How do we make sure that seniors, especially those who don't have the resources, are being monitored so that they don't fall victim to addiction? And then how do we deal with the legal consequences when that happens? And I leave that with you. Thank you. I don't know, Pam or Teresa, if there's anything you want to add about what the county's doing and not doing, I welcome you to come on up. Come and join me. Come on up. Come on up. Don't be shy. No one will cross-examine them, right?
Thank you, County Executive Baker and Teresa. So I'm the health officer for Prince George's County. Thank you. You did a great job of framing it. So opioid, the problem is nationwide, and you know that already. From a public health standpoint, however, once you're addicted, you're addicted. And you all are judges. How you got there is irrelevant after you're addicted. Primarily, you have a medical condition. Your brain chemistry changes, you are addicted. So there are people who want to get out of that lifestyle, and when they're ready to do that, we need beds, we need community health workers, we need treatment that's easily accessible for those. We know that there's a percentage of people who have no interest in getting off of drugs. It's a lifestyle that you have to want to, and it is not easy to get off. It is very difficult. What I don't think we talk about in the country as much as we should is once someone is addicted, it's a different conversation. Your brain chemistry changes. You see people who are addicted to accidental death, Mr. Baker spoke about, accidental addiction. So opioids, oxycodone's been used for years. Most people in this room don't know that the drug was not designed for long-term chronic pain use, okay? It was invented and designed for post-op procedure. Short term, few days, you get it, you're off of it. Go on to Tylenol number 3 or extra strength or something like that. And at a certain point in our country, a decision was made to use it for chronic disease. Chronic pain, not a good drug. It is addictive, highly addictive, and you know. So we're here, not accidentally, not necessarily intentionally, but we're here. So we use it for chronic pain. It's not the best drug of choice if you're thinking about addiction. But once someone's addicted, we really need to talk about now what. I like to say to our team, then what? You've got someone who's addicted, someone who doesn't want to be addicted any longer. What do we have to offer? Is there a treatment? Is it easily accessible? Is it near my neighborhood? Is there stigma attached to that? Will I lose my job? So there's a lot of things to consider with addiction, but I think that the point I want to leave with you is no one is born choosing to want to be a convict or addicted to heroin or an opioid. It happens. Some go seeking a high, others had an injury in college, and now they're hooked. When things change with our pharmaceutical companies to make it a little bit more difficult to get the oxycodone, we started locking things down, as we probably should have had the conversation before we made some changes. Then you're addicted. You need the drug. Heroin, very cheap, very easy to get. And so now you were getting it from your doctor and you didn't, now you're seeking it. So it's a conversation about a medical situation now, once they're addicted. And when we can look at it that way, we may begin to have the conversation about what do we really need to have available for people to get off the drug. That's just my public health approach to how we need to look at this addiction. Teresa.
Thank you very much. Thank you very much. One of the things I want to do, first of all, is to introduce the Advisory Committee on Aging that's present here today, and we certainly do appreciate your presence. If you can just wave your hands, that would be great. Now, one of the things I just wanted to share with you, I'm here, just like everyone else, to learn more about opiate and how it impacts older adults, not just in Prince George's County, but older adults in general. That's a conversation that we haven't had in the past. But one of the things that was interesting, as listening to the data, I've been in the field for a very long time, in the field of aging, but one of the things that I think we need to do is be very, very careful about making assumptions based on the data. For example, when we're looking at deaths in the county, we're looking at 55 and over. One of the things that struck me as odd is when you think about older adults, they run the gamut from 55 to 100. And so basically a person in a 55 to 60 category is going to look very differently from an 85 and older person. But one of the things that we do know, and especially when you think about 86% of those deaths were heroin related, I began to think about the aging of the baby boomers. And how that might impact, the data. And so that's one of the other things that I'm concerned about. So I'm really concerned that we don't jump to conclusions, that we carefully analyze the data. We know that older adults take multiple medications, on the average 5+ medications. And I'm going to tell you, when we do our home visits and we talk to older adults, the first thing when you go into their home, what you see is a cocktail table or in the living room, medication spread all over. And so, when you think about it, I'm looking at it holistically, not just the older adult, but others who also have access to their medication. We've had situations where we've had caretakers who had drug addiction take the medications, of that older person whom they're providing care for. The other aspect that we're looking at is the fact that you have many older people, grandparents, who are now caring for their grandchildren because of the absence of parents because of opiate and other addictions, incarceration, and etc. And so we have to really look at it from very different angles and sometimes from a very different lens. And so there's a lot to learn. What we're going to be doing over the next couple of months is developing our aging area plan for 2018. And what we're going to do throughout the state of Maryland is we are going to have an objective as it relates to opiate, but it should look differently depending on where you reside and what the problem is. So we're in Prince George's County, we're going to be working very closely with our stakeholders. We're going to lean on our health department. They're the experts on this field, and we're going to do what we need to do to develop a plan that makes sense for Prince George's County. We're going to be moving forward to that. So there's a lot to do, but also there's a lot to learn as it relates to older adults and the impact on them and their families.
We are very appreciative. Before Mr. Baker leaves and completes, we start the afternoon session of this agenda. Do you have any questions for him or either one of the beautiful ladies standing?
So I have a question.
Okay.
Yes, ma'am.
The Speaker of the Senate talked about the coordinated plan and there, my understanding was that there was an increase in the funding for drug courts. Then you, sir, indicated that in spite of drug courts, the majority of the population affected is locked up. So
Right.
would you tell us how?
So the increase for drug court expanded, throughout, but it clearly is not enough to get everybody in there. So if they're going to drug court, not everyone is gonna be sent home. And then the other thing before they even get to drug court is that they're actually coming to our jails. So it would be better for us, quite honestly, before we even get to that stage, if I have Mary Lou McDonough, who's head of our corrections here, she's saying drug courts is fine, but before they get there, they're with me. The better thing to do is if we had treatment beds available, we could actually bypass that step and send them straight to the beds that are available and treat it purely as a health-related problem. Because depending on where you reside, it's how long it gets to handle those issues, and I think that's it. So it comes down to, it comes down, as the judge knows, it comes down to funding and where we fund our intervention. And I think, and actually comes down to, quite honestly, the laws. The ability for our police department to bypass that and not send them to jail. The ability of us to make those decisions is where you come in, and that is how do we shape the laws that are going to affect people, which is really at the local level and at the state level. Yes, sir.
How about legalizing it and taxing it? Create a revenue source, pay for those things.
Yeah, and the speaker of the president of the Senate didn't talk about that, but that's something, in terms of, especially around cannabis. I think that's the new word they use now. We just went through a process of, the legalization for medical use, marijuana, and opening up facilities, and we had to remind us, here in this county, 500 square mile, this great educated county right next to the District of Columbia, we had one of the biggest arguments with our county council about opening up these facilities for medical use, not even for personal use. Anne Arundel County, right next to us, has denied having it there. So I bring that up to say it is a very difficult conversation that you have. But once you have it and you're like the District of Columbia, here's the other thing that we face is the laws aren't, and this is where you come in, the laws need to follow the legislation that opens it up. How do you deal with if somebody's coming to work and they have, let's say especially if it's marijuana, if they smell, if the smell comes with them, how do you deal with them when they're high? How do you deal with them around here? So the laws themselves aren't following that. Yes, sir.
Yeah, there was a point when we said alcohol was illegal too.
Yes.
And then we legalized it and taxed it.
Legalize and tax it, but what we also do, as the President was reminding me on his way out, dealing with the liquor board, is that we set up a legal structure on how we deal with it. And that's what I'm saying is not following. So in District of Columbia, where it is legal for you to use certain drugs for yourself, it's how the legal structure follows it. And that's just a fact. It's not saying, you know, I served on judiciary and I know how difficult it is. You can pass something and then getting, you know, and then it falls to the courts. Because the courts end up making legislative laws because they have to rule. So I'm just saying that as we think about the issues we have, that the legal system has to follow it also.
The oxycodone is legal. Harris, I
Yep.
mean, it's the,
Pam?
so oxycodone, it's legal. It's not illegal to use oxycodone. I can get a prescription. The problem that legalizing and taxing doesn't get at is the addiction. And so oxycodone is legal. I can go and get a prescription.
I'm not suggesting that it solves all the problems.
Right.
It's not the panacea, but it solves a lot of problems related to it. For example, legalizing it and taxing it will probably
Create funds.
result in quality control. It will probably result in price reduction. It will probably result in reduction of crimes committed to generate money to buy illegal drugs. It will save on law enforcement and incarceration costs.
But
I think that's an assumption, and I can look, he's going to hit me later. If I talk about the legalization of marijuana, I think the exact opposite has happened in our county and in Washington, D.C. You've got chump young players trying to be big baller drug dealers over $200 shooting grannies in the street because they don't understand that. It's not, I mean, I think it's an assumption. I think it's possible. I don't think we do the hard work up front. I'm a big planner, and this means this is a process. You need to plan, you need to think about all the things that can happen and set up laws and situations and infrastructure to do it the way you want it to go. I think it is possible. I haven't seen us do the hard work in advance before we pass those laws.
Right,
I'm
right.
not suggesting that it's not hard work and that it shouldn't be planned. I'm just suggesting that maybe we need to change the paradigm. And we need to
Well-
change it drastically in order to be able to address the problem realistically.
Right. I think, you know, we were having this discussion actually in Baltimore. Once again, the Harford County executive, where this epidemic is going on, and I were on a show together. And we were talking to her, you know, off camera, and we were saying how Kurt Smoke, anybody remembers, he was mayor of Baltimore, you know, in the 80s. He came out with this thing when they had the drug epidemic in Baltimore that we should legalize it. But no one ever heard, he said legalize it, but he also went down some steps, you know, about how you put a structure in place. But nobody got to the structure. The argument became over legalization. And of course it led him to not have an office anymore. But years later, the conversation where we're coming to is he was actually right on some of it, but it was much deeper than what people were discussing at the time, because what it talked about was setting up the legal structure so that you deal with it. So that's one thing, because that's what the district is dealing with right now, the District of Columbia. That's what Colorado is dealing with. You have these places where we're seeing, you know, this discussion take place. But then we get back to what you asked us to talk about here, and that is the abuse. Because even if we did all of those things, then the question becomes for us, you know, how do you deal with the addiction part of it, and how do you deal with the treatment for that, and how do you pay for it, and how do you deal with diverting them from jail? So the question would be, if you legalize it, the idea, probably if I was going down your train of thought of what I think you're saying, is you would take that money, that would be the treatment portion of it. You would be able to have more money.
Take the tax money and use it for treatment. You would take the money
Okay.
and save on incarceration and use it for rehabilitation.
Right. So there are two things I can tell you as both a county executive and as a former legislator. Now, I don't know any other state, but I do know Maryland. All money that goes into Maryland is in the general fund. There's a big casino right up there that we push through that's supposed to be for education. So the reality, because this is what you're going to have to deal with when you're setting up the structure of it. Once it comes into the general fund, it's used for everything. So it doesn't. Here in our county, or in Hartford County, or any other county, we don't have the ability to tell them what to do at the legislative body with money for treatment or addiction. We can deal with our own money, but none of that stuff is coming to us. Our money comes from property taxes. So what I'm saying is that as we look at these things, right now, even if we move down the road of legalizing some other things, we're still in the catch-22 of what do we do with treatment and what do we do with keeping folks out of jail and out of our judicial system to begin with, so that we start getting help for them. And that's the thing that we're gonna need. Either way, we're gonna need a legal structure that actually makes it possible, and that's where you can come in.
All right, if there are no other questions.
Thank you. Thank you, guys.